Hi, my name is Dr. Libby Sallnow, and I'm one of the lead authors of the Lancet Commission into the Value of Death. And I've also got a range of clinical and academic roles in palliative and end-of-life care. I'm going to spend the next 15 minutes talking about the Lancet Commission on the value of death, bringing death back into life. So the Lancet Commission on the value of death was published in February 2022, and it took a global perspective, looking specifically beyond palliative care and healthcare services and using a systems approach to understand challenges. We'd first been challenged with the idea that death is over-medicalised or over-professionalised. And so to really understand what this meant and to go beyond kind of the simple ideas of more people dying in hospital, for example, we needed to look deeper. And so we looked at structural issues such as gender, race, power, considered alongside relationships, philosophy of death and dying, religious perspectives, consumerism and economics. We reflected on the title during the first COVID wave as we were writing to understand whether this is actually something that we could ever publish and whether it would be a palatable title. But we actually began to reflect more deeply on the kind of crucial and fundamental importance of understanding death and dying, and that though difficult contexts, actually COVID-19 made it even more apparent of how important it is to have these conversations. And rather than just chasing the challenges, we wanted also to be hopeful and intentional. I'll come on to our final kind of output, which helps look to the future of a new vision for death and dying. So I'm going to start by looking at some of the facts and figures of what it's like in 21st century to die. So on the surface, global mortality trends have improved. So global mortality suggests life expectancy is increasing. But if we look beneath the surface, there's disproportionate progress both within and across countries, and specific population groups have seen their life expectancy either stalling or reversing. And we've seen that healthy life expectancy is not kept pace. So whereas people are living for a larger number of quantitative years, actually people are spending those extra years often in poor health. And millions are experiencing serious health-related suffering, which is the concept that came out of the Lancet Commission on Palliative Care and Pain Relief. This is a table from the Commission, which demonstrates the range of different indices that we can see when we begin to understand how, where and why people are dying. The life expectancy between, for example, Malawi and UK is almost 2 decades. And we look at these disparate findings across different countries according to different indices in terms of death from communicable diseases, deaths from non-communicable diseases, suicide, and under 5 or maternal mortality. So there's not just one picture of what is facing people as they begin to die and grieve. This table picks up more of the high and middle income countries to look at where people are dying. Now, place of death is a very poor proxy for quality of end-of-life care or palliative care, but it is an important trend to understand about what's happening. And here we see increased numbers of people dying in hospital and proportionally, and increased spending. The final column looks at the spending in the last weeks and months of life. And we see that is really increasing in high income countries, but increasingly in middle income countries too. So it's not that there's one story really when we look to understand how people are dying and grieving and caring in the 21st century. For some, we see people over-treated, having treatments that they don't wish to have that will either be prolonging their dying or increasing their suffering. And we see this often in high-income and middle-income countries as a predominant mode of death, with people dying in hospital. But this is a trend that we see increasing in low and middle-income countries as well. On the right, there is a map from the Palliative Care Commission report, which was published in 2017. And this is a map of the opioid availability per patient in need per year. And so this is not per capita. And we can see that Canada and Australia are bloated. There's more, the map shows them as larger than they would have their normal place in a world map, showing there's more availability than is needed for patients annually. Whilst we see other entire continents, not even countries, reduced down to just a thin line on a map. And that suggests there's absolutely no availability or extremely minimal availability of opioids for people dying. So it's not as simple that death is over-medicalised. It's not as simple as death is professionalised. For some people it is, and there's too much intervention, but for others there's too little intervention. So to understand how this is happening, and then to begin to think about how this may be challenged and changed, we needed to take a systems approach. And a systems approach is when you begin to scratch beneath the surface. So you might look at the events to see what is happening. And here we may take the trend of increased hospitalization, and you look at this as an event to understand, okay, there are more people dying in hospital. But when you look beneath the surface, so you go one level down, say, well, is this a pattern that has a long-term trend? Has this been happening for many years, for generations, for decades? And when we look back, we see this is a trend that's happening across decades, across generations, and it's happening across high-income countries and increasingly low and middle-income countries. So this is a trend that we see right the way across. When we begin to look at underlying structures, to go one level down, what determines or influences these patterns? Well, then we see shifts in communicable and non-communicable diseases. So more people dying from chronic conditions, less people dying from acute infective conditions. And we see that people are living for longer. So they're living with these conditions for much longer, which changes entirely the kind of expectations of health services and the kind of model of how people are cared for. And as we look further down to kind of say, well, what informs those? Then we'll begin to see that actually there's a shift in expectation of what value is. So where value may have been in a good death, in a home death, or in a death that's not painful, often the value that people or families are ascribing is a value of increased care, increased intervention, increased treatment. The idea that there is always one more treatment, that death is almost infinitely deferrable. There will always be one more treatment to manage that. And this mental model, this kind of paradigm or kind of culture of medicine being able to cure all options, or at least the belief in that, is something which is really underpinning that. So we took this idea of a systems approach into end-of-life care, into death and dying. And here is one model, we include this in the report, which looks at the many complex intersecting factors that happen and are taking place when someone is dying at home. And this is, really to illustrate the kind of lunacy of trying to do a kind of A equals B, A plus B equals C kind of linear relationship that we can just look at developing a new service or increasing opioids in a simple way. Actually, the kind of complexity of factors means that there are so many different aspects to consider when we're really trying to improve end-of-life care. And actually what we need to understand is the role of all these different approaches and the intersection of all these different influences to really begin to shift things in a meaningful sense. So we began to look at what would be a uniting vision to move forward and to begin to shift how people are experiencing care and how they're dying and grieving in a meaningful way on a global level. Quite a challenge. So we used the philosopher John Rawls, a US philosopher, his concept of a realistic utopia. And this is where you begin looking at reasonableness and justice. So the idea of a radically different vision of future society based on justice, but whilst radical, it is also achievable. And so we really looked at how we could reimagine this future of death and dying, reimagine this future for how people could experience these universal events in a way that we would wish them to be, in a way that would tackle many of the challenges, and in a way that would allow us to really imagine what that would look like. So there's 5 principles of the realistic utopia that I will run through now. So the first is that the social determinants, the social and structural determinants of death, dying, grieving are tackled. And here what we want to say is that people are dying in some places, often in the same country, they're dying from in intensive care with treatments they would not wish to have. At the same time, people are dying avoidable deaths because affordable universal health coverage is not available, or they're unable to access that. So actually we need to look at these social and structural determinants, because it's not as simple as saying we need less medication or less medical intervention at the end of life. For some people, actually people need more healthcare interventions, and for others, people wish to have less. And we also want to make it clear the interconnected nature of dying, grieving and living. So how people have lived, the social and structural determinants that have influenced their health, their life, their ability to make choices. those determinants continue into their care and their dying phase. Often they determine why they are dying, what the condition they're dying of. But that shapes their ability to make choices at the end of life, to have treatment options, to access pain relief. And how those people then die in that context, the determinants of how they're dying, then influences how people are grieving and the experience of grief and for those left behind. And those experiences of grief then influence the life of those people as they go on into the future to live their lives, and they can't hold that with them. And so then those influences in their lives then influence the future of their death and their care. And so it's this interconnected nature, and often we see living, health and well-being as something quite separate to dying and grieving, and we say that they must be seen as integral and interlinked. And here we see an example of understanding the context, the social and structural context within which end-of-life care or palliative care services happen. And this is Compassionate Coral, which is a project in Coral slum in Dhaka in Bangladesh, where the project within palliative care, starting a palliative care service, was intimately related with the other healthcare needs, the other social and structural challenges. And it was not seen as a kind of separate add-on service. It was looking at supporting maternity, gynecological, ophthalmic services at the same time as end-of-life care. So the second principle is focusing on the relational aspects rather than just the physiological aspects of dying. And in hospital, often this gets lost. In clinical care, often this gets lost. And so the focus for this realistic utopia for understanding how this could be different is focusing on the role of networks. And this is an example of relationships. This is an example of a compassionate communities movement. You will be hearing more about that from Suresh Kumar about the neighbourhood network in palliative care in Kerala. And this is an interpretation of that, modelled in fact on that neighbourhood network that we initiated in London, to begin creating a space for relationships at the end of life, to begin creating a space for people to connect around this and to actually focus on what really is important at these times, beyond the physiology, beyond the tests, beyond the imaging. The second one relates to networks of care. The third one relates to networks of care. And here we're looking beyond community networks, beyond, say, the communication between primary, tertiary and secondary care in hospitals. We're looking at integrated networks across lay and professional boundaries. And these are essential. When people die well, it's not usually because they have one great physician or one great nurse or one great family carer. It's about a network coming together. And what we see in a lot of the evidence is that these relationships, these networks are taking place really in separate worlds, and they're not communicating across. And what we ask for and advocate through the Commission is that we all begin to understand our roles within this, within these different networks, and begin to reach across boundaries to have conversations, because that's where integration care happens. That's where more understanding across these networks will take place. And this is an example of a study that was looking at the existence of these networks across lay and professional boundaries. And at the bottom, there's the network around the inner network around the carer and the family members and the other community supports around that. And then at the top in black, you can see the community nurse, the palliative care nurse, the doctor. And so here you can see that actually there's just a real separation. There's communication with the main carer or the main daughter, but actually very little integration across that. And what we suggest is that actually at the moment this separation is leading to poor care, and one of the key things for the Commission would be to understand how we can begin building relationships across these differences. We looked at a lot of policies, narrative stories, which suggested that death and dying really are not topics that are covered in policies on health, aging, COVID, many other areas where you would understand and expect a recognition of death or mortality to be included, just not involved. And here, this is the social determinants of health diagram, where we move from prenatal, preschool, school training, employment, retirement, the kind of stages in the life course approach. But interestingly, there's no recognition of death, of dying, of grieving at the end there. And so we call for this to be much more explicitly situated and acknowledged in policy level documents, because then that creates a space to understand what our responses should be, and to begin to understand that actually this is a normal event that will happen in everyone's lives. And actually by omitting it from policies, strategies, guidelines, then we're actually not allowing ourselves to begin formulating responses to it. And this is the kind of corollary of that. The other side of that is death literacy. And so this is trying to make spaces to create skills, capacity, understanding, and experience in caring for people in the community. People are often very frightened, families and communities, to know exactly what to do. And there's a sense that there's been a loss of some of these skills that used to be commonplace. And so death literacy is an idea to actually begin supporting families and communities to build this crucial knowledge. And finally, the most abstract of principles is that death is recognised as having value. And although it's not welcome and it's distressing and very difficult, for some it can be right, it can be natural, it can be the right time. And what we understand is that death, whilst not welcome, is an integral part of our lives. It's an integral part of life. And by devaluing it and not giving it the kind of central place that it needs, we actually create a much harder condition whereby we can't understand the role it plays, and by denying it and ignoring it, actually this leads to further problems. So I'll finish here with the final slide. There's a QR code there that you can download the report from. And the fundamental point for the Commission is that death and dying must be recognised as not only normal, but valuable. Care of the dying and grieving must be rebalanced. And we call on everyone to understand their role in achieving this goal.